All right. Well, welcome everybody. Thanks for joining us for the ICRS webinar hosted by JRF on osteochondral allografts of the knee and shoulder. We're pretty excited about this. We have quite a few participants registered, so I think that the excitement is shared, and almost 50 countries are represented by the participants. So I think that's really great. And the use of osteochondral allografts certainly is different based on the landscape that you're located in, but I think there's a lot of take-homes that could be gleaned from this regardless of that. So we'll try to get into this as much as we can. And Eric Strauss is going to be our first presenter from NYU. Dr. Strauss is going to be discussing the use of fresh pre-cut cores and their use in the knee primarily. And then we'll also go through some cases. He'll be followed by Dr. Matt Provencher from Vail, who will be looking at the use of osteochondral allografts from the lower extremity in the shoulder, which he's obviously had a heavy involvement in and is an expert on. So we're looking forward to that too, as well as some potential cases there. And then I'll be covering the use of osteochondral allografts in the knee, but just more general approaches, overall consensus items on when to indicate them, how to use them, technique aspects, as well as recovery. Please note that we will have the ability to take live questions that we would encourage you to send during the talks so that we could field 1 to 2 of those at the end of each talk, and we'll try to go through those assuming we have time. So without further ado, we'll get started with Dr. Strauss, and very excited to hear both of your talks.
All right. Good morning, everybody. Greetings from New York City. My name is Eric Strauss. I'm one of the sports medicine surgeons at NYU Langone Orthopedics. I wanted to thank all of you for joining us this morning, at least this morning here, and thank ICRS for putting this on and all the support that we get from JRF Ortho. So as Adam mentioned, I'm going to be going over early to mid-term clinical outcomes of on-demand pre-cut fresh cores and giving you guys a case example. So I do have some disclosures that are available on the AOS website. So what we're going to accomplish in the next 15 minutes or so is review the significance of full thickness articular cartilage lesions, spend some time on operative management, mostly what my algorithm is here over at NYU. But really the focus is on osteochondral allograft implantation, talking about size matched osteochondral allografts versus these on-demand pre-cut fresh cores. We'll give an example with a case and then pull it all together. So we're all aware that full thickness articular cartilage defects are an underestimated problem. In these large epidemiologic studies published by Gel and Curl, where they looked at consecutive arthroscopic cases, they demonstrated that cartilage lesions are seen in upwards of 2/3 of patients, irrespective of the surgical indication. We're also aware that when a patient has a full thickness lesion like this, it could lead to the premature development of degenerative arthritis. In the last 10 to 15 years, an evolving basic science knowledge and improvement in the technology that we have access to has created some opportunities for effective surgical treatment. When someone has a full thickness chondral defect like you see here, we know from a number of elegant biomechanical studies that it alters the distribution of weight-bearing forces. A lesion like this one on the femoral condyle will lead to a concentration of stresses at the defect rim and on the opposing articular surface. These decreased contact areas, edge loading, and increased peak stresses that result lead to a biochemical cascade resulting in degenerative changes, including chondrocyte apoptosis and the breakdown of extracellular matrix. In this biomechanical study published by Gutler in AJSM, they demonstrated that defects greater than 1 centimeter in diameter will concentrate the applied loads at the defect rim, and that the larger the defect, the higher the stresses and the more concentration on that lesion edge. For those of us like myself, Dr. Yankee, and Dr. Provencher that really love taking care of complex joint preservation cases, we often will approach our patient and their pathology thinking about this Venn diagram that includes deformity, instability, and articular or meniscus insufficiency. While the case in the center, where the overlap of these 3 things is a lot of fun and very complex, what I'm going to focus on in the next few minutes is that focal isolated cartilage lesion down here. So when you have a patient with a symptomatic focal chondral lesion that has failed to respond to attempts at non-operative management, this is kind of the menu of surgical options. It includes microfracture or microfracture plus, a cell-based cartilage repair in the form of MACI, osteochondral autograft transfer, osteochondral allograft implantation, and that's where it breaks down into either a size-matched OCA or a fresh pre-cut osteochondral core. Many of us would agree that the decision-making is based on lesion and patient characteristics. And for me, it's really the status and involvement of the underlying subchondral bone that helps guide my algorithm. In my practice at NYU Langone Orthopedics in 2021, my workhorses are osteochondral allografts and MACI. And I put OCA versus MACI, but it's not really versus. In my opinion, these are two different operations with distinct indications. For me, cell-based treatment is used to treat surface lesions. This is a cartilage treatment for a cartilage problem. It's often a shear type injury. And for me, it's patients that on imaging have minimal to no underlying bone marrow edema and a normal subchondral bone plate. In contrast, I'm utilizing osteochondral treatments for lesions that have bony involvement. It's an osteochondral treatment for an osteochondral problem. And these are patients who demonstrate underlying bone marrow edema, large subchondral cysts, or an involved or abnormal subchondral bone plate. It can be postoperative, often in the setting of a prior failed microfracture. So when focusing on osteochondral allograft implantation, recently tissue banks like JRF Ortho have provided us with the opportunity to utilize fresh pre-cut osteochondral cores. They come in 10 millimeter and 16 millimeter diameter, and they're readily available. Historically, for larger lesions where matching the radius of curvature is important, we're using a size-matched osteochondral allograft, as you see in the image on the bottom left. So with our utilization of these fresh pre-cut cores more and more for patients, it begged the question, is there any real difference when choosing between the two options for a lesion that's amenable to either? So recently, our group at NYU published this study in the Cartilage Journal. We had 52 matched patients undergoing osteochondral allograft implantation. We had 26 patients treated with fresh pre-cut cores, as you see, 16 males and 10 females with a mean age of 31.5 years. And the other group included 26 patients treated with size-matched hemicondyles with a similar demographic and age breakdown. At a mean follow-up of 34 months with a range of 12 to 99 months, we assessed patient-reported outcome scores and MOCART scores on postoperative MRI. As you see in this table breaking down the two cohorts, it's a pretty well-matched grouping. We have a pretty even distribution of lesion location, including those on the medial femoral condyle, lateral femoral condyle, patella, and trochlea. The mean lesion size was about 2 square centimeters, and you can see the list of concomitant procedures performed at the bottom of the table. We found no significant differences between groups with respect to VAS pain score, KOOS score, Tegner score, or MOCART score on the follow-up MRI. With these equivalent outcomes at early to midterm follow-up, we believe there are some advantages to using fresh pre-cut cores over a size-matched OCA. Number one, there's the ease of obtaining from the tissue bank. You can get a fresh cut core in a couple of weeks, comparison to a few months where you're waiting for a perfectly size-matched osteochondral allograft hemicondyle. There's also a cost benefit. It clearly costs less to get the fresh cores than a hemicondyle or a whole distal femur. And as I'm going to show you in the case example that I'm going to present shortly, it's an efficient procedure. It's shorter because it's much less time with the harvesting of the allograft plug and the preparation compared to just sizing what comes pre-cut from the tissue bank. So here's an example from a case from about 10 days ago. My patient is a 20-year-old healthy, active male collegiate basketball player who came to the office with 5 months of right knee pain, swelling, and mechanical symptoms. He believes that his symptoms started after a knee-to-knee injury during practice. The patient was initially treated by his local team physician with 2 rounds of platelet-rich plasma and formal physical therapy with no real impact on his symptoms or ability to play. He has no past medical history, no past surgical history. He has been taking a leave as an over-the-counter anti-inflammatory. He has no family history. He's a college sophomore. He denies tobacco use. And because his parents are sitting with him in the office, He also denies alcohol consumption. He has no other complaints outside his right knee symptoms. So as you can see on physical exam, he's a tall, lanky kid. He's 6'2", weighs about 180 pounds. He has normal lower extremity alignment, both grossly and confirmed on long leg alignment films that we got in the office. A focused examination of his right knee shows a mild to moderate effusion. He is tender to palpation about the lateral femoral condyle. His range of motion is 0 to 125 degrees of flexion with anterolateral pain on end flexion. And important to note, this is about 15 degrees short of the full flexion on the contralateral side. He has a repetitive painful catch between 70 and 90 degrees of flexion, localizing to the anterolateral aspect of his knee. He has a normal ligament exam, normal motor strength, and normal neurovascular exam. So you see here, his plain films are unremarkable. He's got well-maintained joint spaces in all three compartments and no evidence of bony abnormality. As you see here on these T2 coronal images, he's got a full thickness lesion of the central posterior aspect of his lateral femoral condyle. You also see it here on these T2 sagittal cuts in that posterior central aspect of the lateral femoral condyle. And you can also make it out on these axial cuts. So he's a 20-year-old healthy active male collegiate basketball player with a 10 by 10 millimeter full thickness chondral lesion in the weight-bearing aspect of that lateral femoral condyle. He has continued symptoms despite a trial of non-operative management, so he spent a fair amount of time in the office discussing his surgical options. I felt that he had a choice of either an autograft DOTS, an osteochondral allograft implantation, or MACI. And as a contact athlete looking to get back to play as quickly as he could and hoping to avoid any potential donor site morbidity, as a team, we decided on an osteochondral allograft using a fresh pre-cut allograft core. I made sure that I had a 10 millimeter and a 16 millimeter diameter core on hand in case the lesion ended up being larger than we anticipated based on the MRI. So here's a video of the case. As you see, he's supine. We've got a sterile triangle, and we're going to make a midline incision as you see here. We're going to raise soft tissue flaps both medially and laterally. And I like to make my arthroscopic portals within the approach just for cosmetic reasons. So here we're making our lateral viewing portal, and we're going to commence with our diagnostic arthroscopy, as you'll see. So we create our working portal after spinal needle localization under direct visualization medially. Here's a look at that medial compartment. His medial meniscus is intact. He's got a stable, intact posterior root, as you see here, and the articular surfaces of the medial femoral condyle and medial tibial plateau are pristine. His ACL is normal in appearance and stable to probing, as you see here. And we're going to make our way into that lateral compartment. We initially saw some fraying of the cartilage close to the notch, which we're going to take care of debriding with the arthroscopic shaver. As you see, his lateral meniscus is intact throughout and stable to probing. Get a little loose body, came to say hello, so we took care of that guy. Take care. And here we're going to localize the site of that chondral lesion in the lateral femoral condyle, as you see. He's got a large flap, which is makes sense with respect to his mechanical symptoms, which we're going to grasp and remove from the knee. And this exposes that full thickness lesion. As you see here, it's a 4 millimeter shaver, and we're going to measure the dimensions with the probe. So it's accurate. It's about 10 by 10. So having completed the diagnostic arthroscopy and removing the loose piece, we're going to convert to our open portion of the procedure. And I'm going to extend that lateral portal into a lateral parapatellar arthrotomy, as you see here. We're going to take the approach carefully distally with a finger on the lateral meniscus to make sure we don't injure the anterior horn. I do like to take a little bit of the fat pad to improve mobilization and exposure. We're going to get a Homan in laterally, a Z retractor in, and there's the Homan, and we've got exposed that lateral femoral condyle lesion. As you see, I like to use an Alice clamp to kind of put a little bit of gravity tension on the anterior soft tissues. Here's a 10 millimeter sizer, and I think you'd agree it does a pretty good job of covering the extent of that lesion. So this is the alignment guide from the set. We're going to make sure that we're as perpendicular as possible to the lesion and drill our initial guide pin. So everyone's checking and confirming that we're nice and perpendicular, and we've got it completely covered. Here's our circulating nurse opening that fresh pre-cut osteochondral core. And before I ream the lesion site, I like to measure the core to make sure that I understand how big it is. I don't want to ream any deeper than what I've got to avoid having a recessed plug. So you see here, it ranges from 10 to 13 millimeters. The head of this 10 millimeter reamer from the Tenodesis set is 1 centimeter. So our plan is to go directly to the utilizing the entire head of that reamer. So we're going to have a prepared lesion 1 centimeter in depth. We're going to basically clean up the edges of that lesion, prepared lesion site with a 15 blade. And here's that alignment guide that also serves as a dilator and a measuring tool. But I like to confirm and make circumferential measurements with this small ruler. And you can see here, we're pretty symmetric with about 10 millimeters throughout. I utilize the guide pin to create a couple of marrow venting holes in the base of the lesion to encourage bleeding, which I think improves later incorporation of the bony portion of the plug. We're then going to carefully use that small ruler to basically go circumferentially around our 10 millimeter fresh core. We're going to basically mark out just like you would for a size matched allograft. And we're going to create our plug, measuring twice and cutting once. So once we've got our measurements all made and marked out, here's the osteochondral core in our clamp. And we're utilizing an ACL saw without a stop to really make sure that our plug is perfectly prepared. We're then going to use a rasp to bullet the edges of the prepared plug to ease an insertion. We're going to utilize a pulse lavage to get rid of as much marrow elements from the donor as possible. And I do like to soak the plug in either PRP or BMAC. It was PRP in this case. So you see here, we've implanted our fresh pre-cut core, thumb pressure, minimizing any tamping, and we've done a fair job of reestablishing the articular surface, that lateral thermal condyle. We'll take all of our retractors out, and I put the knee through a large number of ranges of motion because I want to make sure if there's any evidence of mechanical symptoms, clicking or catching, I want to know about it now, and you get a thumbs up from the team. So we're going to pulse lavage out the joint. Since this was a blunt impact, I didn't think a lengthening was necessary, so we're just going to close that lateral arthrotomy. And once it's closed, I do like to utilize the remaining PRP and put it into the joint. So here's one last range of motion check. Things are looking good. We're going to inject our PRP back into the joint through the closed arthrotomy. Do our closure. I like to use 3-0 monocryl and seal it with Dermabond, as you see here. And that's the end of a case. A nice, efficient procedure utilizing that fresh pre-cut osteochondral core. So the patient is toe touch weight bearing and a hinged knee brace for 4 weeks. I do utilize a CPM for 4 to 6 hours a day for 4 weeks. The patient's involved in formal physical therapy for range of motion and strengthening with goals of 90 degrees by 4 weeks and full range of motion by 8 weeks. I spoke to this patient yesterday. He's 10 days out and already hitting 90 degrees. We have him on a stationary bike at 4 weeks, the elliptical at 6 weeks, and we'll advance him back to activities as tolerated somewhere between 4 and 6 months, depending on his return to play assessment with our physical therapist at the hospital. So with respect to tips and tricks, as I finish up here, if you're going to err on preparing the plug, it's better to slightly undersize than leave it proud to avoid any postoperative mechanical symptoms. As you saw, we like to bullet the plug edges to aid in insertion. And I have seen an anecdotal benefit of soaking my graft in something orthobiologic, either PRP or BMAC. And I've seen in my postoperative MRIs in patients that I'm soaking the plugs, less peri-plug bone marrow edema, and I think it makes it speeds the incorporation of the bony portion of your plug. You want to seat as best you can with thumb pressure to minimize impaction with the tamp, because we all know that every single time you hit that osteochondral allograft, you're causing superficial chondrocyte death. So to summarize, what hopefully I've demonstrated is that fresh pre-cut cores are an excellent treatment option for symptomatic focal chondral lesions. There are definite benefits with respect to availability, cost, and procedural efficiency. And our study, and hopefully others that come out soon, show an equivalent outcome. So I think it's something we should all have in our armamentarium when taking care of patients with symptomatic focal chondral lesions. So I appreciate the opportunity to participate in today's webinar, and I'm happy to take any questions that you all have.
Thanks, Eric. That was awesome. We did get a question from the audience, and it kind of pertains to something that'll come up in my talk, so we could probably field it then. But I wanted to ask you, where do you see the role of single stage versus two-stage cartilage treatment? And I think there's two things to potentially cover. Obviously, this patient, and thinking about like an in-season or out-of-season athlete versus somebody that's just not athletic, and that's not the concern. How often do you do debridement and staging?
So I think that's a great question. I think besides in season, out of season, I think it's also, I've been utilizing diagnostic arthroscopy more and more whenever I have any questions about the extent of the pathology. I'd much rather have that patient undergo a 15-minute arthroscopic assessment where I really get a feel for the dimensions, the depth, the status of that ipsilateral meniscus, the opposing articular surface. I think you lose very little and you gain a lot with respect to understanding the pathology. So you're not getting caught unprepared when you come back to do the definitive procedure. So I have a pretty low threshold for doing a diagnostic arthroscopy. And if I do have an in-season athlete that is just looking for a little bit of symptom improvement to get them through, I agree with you that a diagnostic and potentially therapeutic procedure where you're debriding the lesion has upside. But we're all going in eyes wide open that this is likely not the last procedure they're going to have. In this case, we did go straight at it because I was comfortable with my understanding of the lesion. The fact that I knew it wasn't going to be greater than 16 millimeters. So I had both sides fresh pre-cut cores available. I thought that going after it single stage to get this athlete fixed and on his way to recovery as quickly as possible made a lot of sense.
Yeah, no, that's awesome. It looked great. I'm sure he'll do awesome. Thanks for sharing it. Matt, do you want to go ahead and get started with your talk, or do you have any other, if you have any comments you want to add to that? Otherwise, you could go ahead with your presentation if you're all set.
Yeah, no, great, Eric. Thank you. The pre-cut cords have been fantastic. My question to you, Eric, is sometimes you get in, you're like, okay, it's maybe a 10 or a 16. You had two available for that case. How do you manage having the right pre-cut core? And I'll tell you, they come very nicely sized. I mean, a 10 is truly like a 10.0. It fits very well. A 16 is 16.00. It's very nice. And then my second question is just depth of bone as we get lower and lower using, bug B and saw, and, you had 10 millimeters there. And a lot of people ask about, is it 3 millimeters of bone and 2 of cartilage, or, what is the 5, 6, 7 versus 10 like you did? And I'll get my slides ready while I turn those.
So
Thanks.
those are both great questions. One, my kind of go-to is unless I'm 100% sure that I know it's one or the other, I typically will order one of each size plug. Even having 2 plugs there, it's still a cost savings compared to having a hemicondyle or a whole distal femur. As you all know, it oftentimes, this goes back to Adam's first question. It always ends up being a little bigger than you think it's going to be based purely on MRI. So if it's in that 10 range, I'm going to be more comfortable if they have that 16 on backup. But I'm going to try and fill that defect with as small a plug as I can, because you don't want to take away good healthy cartilage. With respect to your second question, that's something that comes up a lot. And it's interesting because when I'm doing a larger plug, I will create, I'll have a smaller bony portion, either 6 or 8 millimeters. But I found that when I'm doing these, especially the 10 millimeter core, it's a much easier procedure just with the instrumentation we have to make it 10. You can utilize you're perfect if you just use the head of that tenodesis reamer. And I don't think I understand you're trying to minimize how much donor bone you have for any kind of immune response. I don't think it's that much that it changes. I think it's an interesting thing to study, but I have been going 10 millimeter length for my 10 millimeter cores and smaller amount of bone for my larger plugs from the hemicondyle.
Great, thank you. Adam, should we move on?
Great. Yeah, that'd be great. Oh, good.
Well, thanks everyone for joining us. I certainly would echo Adam's comments, and Eric's very innovative. It's great stuff. Those cores have really helped us with off the shelf. Then also from an insurance standpoint, it's been fantastic. We can talk about that as well too. So I want to thank JRF and ICRS for helping set up this webinar. I think it's great to get together and share our thoughts and cutting edge areas of osteochondral grafts. And I'm going to talk about the glenohumeral joint. These are my disclosures. They're also on the AAOS website. So we're going to talk about really the glenoid and humeral head and how we can utilize some fresh osteochondral grafts, namely borrowing from our foot and ankle colleagues to be able to do these well. So let's just talk briefly about bone loss. Not all bone loss is the same. You can have acute fractures. We looked at more than 400 patients on CT scan with shoulder instability. It's very interesting. Many have this partial resorption or partial attritional amount of bone loss. You can see that little fragment of bone is not enough to reconstruct the glenoid. And then you can have very fully attritional and very large, massive defects in patients that have numerous dislocations or an acute fracture. Type of bone loss certainly guides treatment. When we look at the attritional bone loss, we're probably underestimating this quite a bit. And we do know the importance of fixing that bone on the front, and even 3, 6, 9 millimeters of surface area of the glenoid to reconstruct is very important to make sure we have good stability ratio and the mechanics of the joint restored. So one of the things we talked about was the distal tibia, and this was why do we use this? So, although JRF does a fantastic job, we are tied to our donor agencies and how we harvest, and it's just very difficult to get a fresh glenoid or scapula products or even humeral head products. And for anyone out there who's had products on order from a fresh osteochondral allograft, even a frozen in this area, it's very difficult because of a lot of donor concerns, contamination concerns as you get more to the central core of the body, unlike the knee and ankle and elbow and other areas we take, you get a much higher contamination. And if you get what's called a class 3 contamination, all of those allografts, including soft tissue, are not allowed to be utilized from that cadaver and from that donor. So it's really about respecting the gift of life, donor concerns. So in the mid to late 2000s, about 2005, 6, I asked the question of, okay, well, that's great. I'd love to get a fresh glenoid and be able to reconstruct this just like we reconstruct defects in the knee and many other places. And I said, well, what don't you use? And they said, well, we do a lot of talus processing for our foot and ankle surgeons to do talus plugs, but we throw away a lot of distal tibias, and they go together for processing. And so here's the distal tibia, and we started first with very large defects, or a really nice indication was a failed Latarjet or after you had a bone procedure, and then other cartilage and bony problems were usually are 20%. Or you're thinking more that this is not just bone loss, but also an issue with the surface and restoring concavity of the glenohumeral joint, which is very important to restore the mechanics. So this was our initial one that we published after a few years of follow-up, and we had a really nice conformity. It was actually a football player, and he was a young 20-year-old. It had numerous procedures and a postage stamp fracture after numerous anchors, and really had a ton of bone loss, and did very well after we did the first one. So how do we do this? And generally, you can do this in the beach chair, but you also do this laterally. You just need to be able to get at this. We started always with an open procedure, but now we're doing many of these arthroscopic. I always do a subscapularis split. And so I basically make this subscap split about 2.5 to 3 centimeters down from the top of the rolled edge of the subscap. Very nicely, you can see now the capsule. We have to protect all these structures medially, as I'll show you here in a second. And you can see that capsule that we're going to now do an L-shaped capsulotomy on. This is why this is where we do this, 2/3 and 1/3. I only split this in line with the fibers. Once I get into the muscle, maybe about 1 centimeter, we stop because we want to protect all the vessels medially. And why do we do the split, even when you're doing a Latarjet or any bone type of procedure, and any type of bone that you may put in there? There's tenotomy has been shown to have more atrophy and loss of rotation and almost pseudo instability symptoms if that subscapularis does not do well. So I don't like violating the subscapularis. This is a Latarjet depiction, and what happens after Latarjet. Many times we're doing these distal tibias after Latarjets for resorption or other issues, or just non-healing. And so you can see when we look here, the Latarjet is actually very close to these structures. So you have to be really careful about in this area when we're operating medially to the glenoid. And especially after a Latarjet, where I have what I call these naked vessels after you take down that conjoint tendon. That conjoint and coracoid is very protective of them, but you have to be careful once that's down. So then we look at the anterior glenoid prep after doing the tenotomy. And I think really the key is to get the glenoid perpendicular to the cartilage surface and a good bleeding bed. You can use a small high-speed burr, you can use a power rasp, or here I have a hand power rasp. But the key is to really get this prepared perfectly. You have to get a good bleeding bed, just like we do in the knee or any other osteochondral allograft. We're going to be able to fit in some template sizers, and there is a commercially available set to help us with this that you can obtain and then help you get this done. So after we use a 3D CT to assess, I sort of know the size, but you also can use the templates. And anywhere from 6 to 10 millimeters of surface is what we're taking. And here's the distal tibia, and you can see the nice concavity. When we studied this, it had a very nice fit and a very nice feel to the overall graft and match of the glenoid. And this is basically what we're taking, is that area right there. And it's anywhere from 23 to 25 millimeters. You can do this freehand, which is certainly how I first started for about the 5 to 6 years of first doing this. And then had this development of a graft holder, which is commercially available for you to be able to utilize and really size the graft perfectly to the defect. I always use a 10 millimeter thin saw blade. Coincidentally, it's the same one I use for osteochondral allograft or BioUni or in the knee. I'd really like that nice 10 millimeter thin blade. You can use the guide and the sizers. We then pre-drill the holes. You have to make sure that these are far enough away from the cartilage surface, because I do use washers and suture washers with my screws to be able to hold it. And the key angle is about 10 to 15 degrees when you're putting this in the glenoid. We do our final cuts after we do the screws, and you can actually see different slots here for different sizes of graft to be able to put this in place. And they're anywhere from about 18.5 millimeters to 23, but you can also slide this jig and really get any size that you want. So we're able to take this graft, harvest it, it easily comes out. We put it in a commercially available holder, and you can see that's basically what we want. And it almost just looks like our Latarjet, except we have very dense corticocancellous bone. I'm putting in the size of it to show what we did for the harvest technique, and then putting this in place to make sure that we follow that template. As Eric nicely pointed out, don't forget your pulse lavage principles and OCA principles, which are very important. I also soak this in PRP or BMAC prior, and that is very important, I think, as Eric Strauss pointed out as well. After you put this in using the holder, I do use 2 small K-wires just to hold it, and usually is about 23 to 28 millimeters, and then 6 to 12 millimeters medial lateral, just depending on the size of the patient. But usually I'm around a centimeter from medial lateral. I do use solid screws. I do use suture washers. And then you can see, this is another patient, but you can see the graft that just nicely fits the contour and concavity of that glenoid in a very large bone loss case. And what's really interesting is how the humeral head nicely approximates the articulation. You can tie down the capsule anteriorly using a tension slide technique. You can use these screws and washers. There are multiple options to repair the capsule. I've also used anchors around this, just like we do a Bankart or a typical open Bankart, or even arthroscopic Bankart repair. There are arthroscopic instruments and hooks, and you can get pretty creative, or you can use these suture washers, which are commercially available. And these are pretty slick to be able to tie down capsule, and you can do a tension slide. And there's a needle on the end of one of these. You can do a tension slide, and it's integrated into the screw. So what are our outcomes? This is really our first publication on it. We had 27 patients, and we have to be really careful about when we talk about graft lysis. I think it's the same in the knee when we're talking about osteochondral allografts. Our WOSI scores in ASES did very well, and we had overall 90% of the bone that we put in stayed. So there was very little graft lysis. And what I think we need to really talk about is interface healing. And we got CT scans on all of these folks just to make sure we were getting healing. You can see letter B in the bottom right. Sometimes if the angle was a little bit higher, and that showed a little bit higher lysis than we wanted. But the interface healing rate between the glenoid and the bone, I think, is really what we need to be talking about. And then the overall restoration, because there is some level of remodeling and Wolff's Law remodeling. What about as a revision procedure? And I think many of us that are on this call that do this have seen these. And you have non-union, you have full attritional resorption after a bone procedure, say a Latarjet or an iliac crest or otherwise. You can even get osteoarthritis, and there may be a role, especially in the young patient, for this. And we've done some of these as well. So this was the failed Latarjet procedure, and there's not a lot out in the literature on this, but prior to their revision procedure, in which all these patients underwent, distal tibial allograft for a failed Latarjet, about 80% of the bone graft was gone, meaning the Latarjet coracoid had resorbed. We usually rule out infections. Sometimes it's staged, just depending on timing, with an arthroscope and tissue biopsies. And then sometimes we come back and then do the final case. Sometimes we do it in one stage, just depending on their patient history. There's a lot of complex decision-making that goes into that. And here you can see our overall scores with the revision after Latarjet. Not as good as the primary on the WOSI scores, but pretty good. We had about 85% WOSI of normal. SANE was in the 91, ASES 92. And this is what we're talking about here. And this is how I think we have to communicate. We had complete union at the glenoid DTA interface in 28 out of 31. And if you looked at all of them and pulled all of them together, 90% of that interface had fully healed. So I just want to quickly talk about our last graft here. If the DTA fits the glenoid, well, will the talus, which is the other part of the ankle, fit the humeral head? And this has already been processed. Our foot and ankle surgeons use this quite a bit, but obviously we know what the talus looks like. And here's a case, a 35-year-old female, left shoulder pain, dislocation. She actually dislocated her shoulder mountain biking in Vail, Colorado, where I practice, and was taken to the OR for closed reduction. And you can see this is what the shoulder looks like after closed reduction. But even before closed reduction, the ER got CT scan while it was dislocated, which is good because these can be missed. Why can these be missed? Posterior dislocations, because they feel most comfortable in a sling and internal rotation. And so you can see the problem with reverse Hill sacks on this side is it's almost all cartilage. And you can see it on average, when we looked at our reverse Hill sacks, there were about 43 to 45 degrees of the 180-degree arc of cartilage of the humerus was missing. So you're talking a significant portion. And so take down the top of the subscapularis, similar techniques, but you can see these are almost always in the shape of a orange or lemon wedge. And we're doing multiple measurements, including depth, height, what the apex looks like. And so this is basically a back and forth wood shop class to be able to just machine this and put this graft in. There's the first iteration of it. Yeah, a little too big. We'll bring it on back and keep going back and forth using similar techniques, keeping the graft cool, using a thin saw blade. And then when we're fully there, we'll soak it in PRP again. And then this is what we end up with at the end of the day. And it's amazing how well the talus reapproximates the humerus. And then we'll repair subscapularis with standard techniques. But you can see we restored all of that cartilage loss, which is very challenging to fix primarily. You can't tamp it up. It's crushed like an eggshell, and it's very challenging. All these techniques have been described, but this has provided us a very nice solution. And we've also now used these for standard Hill sacks as well. And so here they are now at 1.5, that should be 1.5 years post-op. And overall outstanding healing of these grafts in the humerus, I think just because of the excellent blood supply. So I want to thank you for your time and appreciate you coming to the webinar.
Thanks, Matt. That was awesome as usual. And we did get a question from the audience that we'll go ahead and answer. We can cover live. So the question is, do you do anything ahead of time to prepare for graft resorption or graft lysis? Do you change? Is there anything you do with the size of the graft, the location of it, that you think helps mitigate it, or do you think it's just a biological issue that you can't control?
I think, first of all, about 50% of these cases for me are revisions. You want to make sure that there's no subtle infection. P. acnes is still a very strange bug. We don't know really how its behavior on grafts or autografts for that matter, or allografts. So, but I think we still need to mitigate that risk. The second is I do love PRP and BMAC. And the third, like you mentioned, Adam, is there is some Wolff's Law remodeling, and you're going to get, quote unquote, some lysis of that graft no matter what to really remodel. And you can look at it in the coracoid autograft, iliac crest autograft, or with the distal tibia. They all sort of remodel to this new, the usual pear shape of the glenoid. And so we talk about lysis, but it's probably just going back to a functional normal size or near anatomic glenoid. It's amazing how the body remodels that. That's what we found with our CT scans.
Yeah, awesome. Eric, I think you're muted.
Hey, Matt, it's amazing what you've done, research-wise and driving the clinical treatment of bone loss around the shoulder. It's amazing. So it's good to know you, my friend. But I have a question. At this point, with your experience, how are you determining between using a distal tibial allograft or a ladder J as a primary treatment instead of just revision? You know, are you, with your experience, are you shifting more to DTA, or is ladder J still have a primary role in your approach?
Yeah, Eric, great question. I appreciate your comments. The reality is this is still evolving, but if you look at our European colleagues, they've done a great job on the arthroscopic ladder J. This is where this is going. This is actually an easier case arthroscopically. It's easier to get to. It's easier to get good trajectory. The screw is easier to get a perfect look at it because of the arthroscope is not forgiving, whereas our naked eye, when we're opening, it's a little more forgiving, and the angles and other things can be off, I think, a little more in the open procedure. So I think we're going to an arthroscopic approach. With that being said, in general, I look at it more of a, not just a bone, but also a cartilage and joint concavity issue, and their age and their demand. Contact sport certainly plays into it. So I think there's quite a few things that go into this, Eric, but at the end of the day, if in general, if you have more than 15, 20, 25% of glenoid bone loss, if you have an off-track lesion, and if you have some other factors, such as the patient is quite young, then I'll primarily do a distal tibia, and the results, I mean, that's what we did primarily. The results were very, very good, and they feel very natural. I think the cartilage adds a lot to this joint, and I think they feel good and smooth when that graft is put in and heals appropriately.
Excellent.
Awesome. Thank you both very much, and I'll try to move along just so we can stay on time, and then we'll try to answer any remaining questions. I don't think I said it at the beginning, but my name's Adam Yankee. I'm at Chicago and at Rush University in Chicago, and again, thanks for having me. So I'm going to talk about some kind of rapid fire issues about osteochondral allografts, in particular in the knee. I do have some disclosures that are available online that are pertinent to this talk. Just to reiterate, osteochondral allografts are the only full articular hyaline cartilage that you can implant in a knee, and everything else tries to grow that, but this does have it at time 0, and the goal is to maintain it. So we don't want to injure it as we put it in. We don't want to have problems with it after with regards to healing and incorporation. We want to make sure that it's processed appropriately. And we know that the outcomes long-term are still very good, but they're not 100%. And we do have about 85% survival at 15 years based on multiple studies. And we just want to try to optimize that as much as possible. So it takes a lot to get these grafts. We have donors that are willing to utilize, others utilize this tissue. We want to make sure we're doing our due diligence to improve our outcomes. The MOCA group, which was mentioned earlier in the talk, or which is the Metrics of Osteochondral Allograft group, is a group of multiple surgeons that are high volume and osteochondral allograft usage. And that group has worked to put together some consensus statements talking about what we think is most appropriate based on expert opinion. And then there's also some component of research to back this. And I want to kind of cover the statements, but also the research that backs it. And if it's 3 stars, it was 100% agreement amongst the group, and short of that was 10% agreement. And this has to do with general factors, indications, operative technique, and post-operative recovery. So this talks a little bit of a laundry list, but we'll try to just hit some high points. I know there were some questions in the chat with regards to some of these items. It'd be nice to have a way to test viability and the metabolic activity of osteochondral allografts. It doesn't currently exist. We do know that the best way to maintain that currently that we're aware of is to try to decrease the overall preservation time. There are different preservation techniques. Some are cryopreserved, some have different media that they're in. Some of that still needs to be proven out, but the data that we know currently is that while there can be differences in clinical outcome based on graft storage, if you look at the length of storage, the studies that had storage for less than 20 days did not have a difference in outcome, but those that started to store it longer than 20 days started to see a difference in survival. So all storage doesn't change it. There's probably a critical threshold that if you get beyond that, that it's no longer viable or metabolically active to function the way that we would want. Sizing of grafts can also be a difficult topic because we want to make sure that we have the best amount available to patients. That if we're too picky, then we won't utilize grafts that are available. And if we're too lax, then we'll have poor outcomes due to issues with matching. Most agree that osteochondral allografts could be matched on condyle width or tibial width for the femur specifically. This is measured 1 centimeter down from the roof of the femoral notch. And again, this can either be measured on MRI or the tibial width can be measured on X-ray. And you really just don't want something smaller. You can usually accommodate for a graft that has a larger radius of curvature. A smaller radius of curvature results in a proud or blistering type osteochondral allograft versus something that might ultimately be slightly flatter, which I think most of us would be willing to accept. When it gets into the trochlea, most physicians are still using tibial width, but some others are looking at trochlear width as well as the depth of the trochlea. And we're working on some three-dimensional studies to try to give some guidance here, because it's certainly a more complex topography than on the femoral condyle. We see the same thing on the patella, where you have to deal with the median ridge, the odd facet. There can certainly be some abnormal topography. And when it stays in the lateral facet, it's usually not too difficult. But as soon as it starts to cross, or if it's distal medial with patients with patellar instability, this needs to be taken into account. You can see that most surgeons don't use tibial width anymore when it gets to the patella. And there is some guidance now to try to help with this. There was a study that was done by Dana Piasecki that looked at X-ray measurements and saw that articular length as well as patellar angle had one of the best correlations with the gross anatomy when you look at that on X-rays. So that was a good surrogate. We did some three-dimensional modeling that looked at bone height as well as cartilage height, and we found that these two factors were well conserved. So that means that there was not another good surrogate for the bony height of the patella or the cartilage height of the patella, whereas the width of the tibia correlates pretty well with the cartilage width of the patella. So I think that you can see how tibial width will get you part of the way with regards to the overall width of the patella itself, but it won't tell you about the overall level of dysplasia on the patella. And you can see here how the bony height of the patella can be very different than the cartilage height of the patella. And ultimately, the cartilage height is what matters. When we looked at matching differences on the most common locations to have osteochondral allografts, we saw that you can have really a good cartilage match. You get different amounts of bony mismatch depending on the donor location. But again, the things that predicted the best matches were cartilage width showed up in almost every defect in every location. So I would say that that's ultimately the most important one, followed by cartilage length. When we look at the use of contralateral grafts for osteochondral allografts of the femur, it has been shown that through computer modeling that as long as you're 25 millimeters or less, that you can use a contralateral orthotopic osteochondral allograft, which means instead of taking a medial for a medial defect, you can take a lateral from the opposite side for a medial defect for that donor. And this shows here that you have good cartilage matching on the medial for medial, and the cartilage matching for lateral for medial is really very similar. You have slightly more bony mismatch for lateral for medial, but it's unclear if that really has any clinical significance. And when we look at that actual cutoff, if we look at the actual measurements, it's still, all of this is less than a millimeter different with regards to subchondral bone, which would be our critical cutoff for articular surface mismatch. And we will look at articular surface mismatch between lateral or medial for medial. They're all less than 0.5 millimeter. So most of us would say that that's within acceptable range. And so contralateral or lateral for medial grafts is a real thing for 25 millimeters or less. When it comes to indications, you've heard some of this already with Eric's talk, but revisions is definitely a workhorse for osteochondral allografts. Bony defects such as OCD osteonecrosis or bone voids. And then if they have issues related to potentially the onset of their defect, like meniscal abnormalities, instability, those certainly need to be addressed at the time of surgery and shouldn't be ignored. When we looked at the outcomes of revisions, so after failed microfracture, there's been at least 3 authors that have reported on this, and all of them have shown that there is no difference in outcomes of an osteochondral allograft after a prior failed marrow stimulation compared to the primary outcome without a prior procedure. And so it is a good surgery for that and in the revision setting. When we get into some of the technical components, you've heard both Matt and Eric talking about the depth of the grafts. It was determined by consensus that 6 to 10 millimeters is the ideal combined depth of the graft. There has been a paper, and Andreas Kamal did this work, looking at the size. And as we get smaller and smaller, and Dr. Bugbee has worked on showing some of the allogenicity that can be a problem with regards to marrow elements if they're not fully lavaged. So we want to get a smaller amount of marrow burden. But as you get too small, you might actually have less tight press fit, which can lead to larger cystic formation, which in this setting with Andreas's study, he saw that if it was less than 5 millimeters in thickness, he had actually more cysts form on MRI post-operatively. So I think that's something else to take into consideration. Not part of the consensus statement, but also talking about shells versus plug grafts. At least in the patella, the shells seem to have a worse survival compared to plugs. And I think there's a preference for utilizing plugs as much as possible and only using a shell when absolutely necessary, because the incorporation is more difficult and the fixation is less secure. With regards to the cysts, again, if you have a bone void deep to it, that should be bone grafted, using ideally autograft bone. And we should not try to just fill that with a plug to try to decrease that allograft burden. And then when it comes to preparing the grafts intraoperatively and performing a lavage to remove these marrow elements, there are different ways to do this. And one of them is pulse lavage with saline. Here you can see on the left what it looks like prior to lavage. And then after the lavage, you can see that that pink area is significantly less. But if you look in the deep aspects adjacent to the articular cartilage or the subchondral bone, there is still some marrow elements that are visually still present. And when we started to look at the difference of using pulse lavage versus carbon dioxide high pressure gas in association with this, we saw that when you add the high pressure gas, you actually get significantly less marrow elements in the deep zones compared to when you use pulse lavage alone. So we looked at these in three separate zones. In the superficial middle are arguably similar with lavage alone. And here you can see using the carbon dioxide. And when we actually use this high pressure gas and you apply biologics, you can see how it really gets absorbed, because it doesn't have that oil and vinegar aspect that you can see on the left, which is typical application just after pulse lavage alone. So while this hasn't been studied outside of a lab setting with regards to clinical outcomes, I do use the Carbojet or the carbon dioxide system to try to use to remove any remaining elements, including saline. And there's multiple commercial manufacturers that this is available through. The use of biologics here can be controversial, and you can see that myself and Eric and Matt both do utilize this. And the results for PRP and VMAC are somewhat all over the map, and some studies say that it helps, some say that it doesn't. If you really try to look at this a little bit more closely, or I'm sorry, before I get there, this is a randomized trial that we were part of that was supported by JRF, which looked at the use of bone marrow aspirate concentrate in a prospective fashion for osteochondral allografts, and we saw that there was significantly less cyst formation overall with the use of bone marrow aspirate concentrates, and then more significantly, there was no significant large cysts that were formed. There was more small, but less large, and the total was less. Another interesting finding, which was really unexpected, is that we had better clinical outcomes at 6 months after surgery in the patients that had BMAC utilized at the time of implantation. So I think that was kind of an interesting finding. So again, if we take our study as well as the other 3 studies that exist in the literature, and you look to say, well, which ones show that it helps and which ones don't, there's quite a bit of heterogeneity in these studies, what time points they looked at it, what the outcome was, X-ray, MRI, CT, as well as the scoring system that they utilized and the preparation of the defect. So these are things that we still just need to have high levels of evidence. And I think that the pendulum is swinging towards utilization of biologics to improve the incorporation of osteochondral allografts. The final topic I want to cover is just recovery. And so most people for weight-bearing lesions would recommend 6 weeks of non-weight-bearing or at least partial weight-bearing during that time. And if it's a patellofemoral lesion, then it's weight-bearing, it's tolerated with the leg locked in extension to prevent that weight-bearing throughout flexion. And most would not return sooner than 12 weeks to high-level activities, and that range goes as high as 12 months would be on the other end of the spectrum. And so I think we're all a little bit different in our tolerances for that. And I think that that depends a little bit on the patient and their willingness to try to push forward. I will get, if I have a patient that's at 6 months and they want to really do high-level impact activities, I will get a CT and an MRI in that patient. And if I say I see something really concerning on there, that I might say give it a year unless it's really crucial. But the issue is that MRI and structural findings and clinical symptoms do not correlate very well. So you can really mislead yourself there if you're not careful. So I'll kind of just go through two brief cases here. One illustrates a point that was already discussed, and the second one I think is just an interesting, difficult situation. The first one's a 30-year-old male who had 4 prior knee surgeries. One of them was microfracture with biocartilage, which was 14 months prior to the presentation. Continued to have pain after a small pain-free interval immediately after surgery. Looking at the radiographs, we can see a small subchondral cortical irregularity. He's in mild varus that's less than 5 degrees just at the medial tibial spine. And when we take a look at his MRI, we can see significant subchondral bone marrow lesion with overlying full thickness chondral damage, or at least lack of hyaline fill. This is what his arthroscopy looked like. I did do a staging arthroscopy here. And you can see that this did fill with tissue. It just takes a long time to mature. And at this stage, he still wasn't seeing any signs of relief. I didn't feel like giving him more time alone would be beneficial. And so we curated this out. We tried to remove any loose pieces that could have caused symptoms for him. And then we moved forward with the osteochondral allograft transplant to try to address the cartilage and the bone, which can be seen here. And this patient did ultimately very well. These patients also usually see a significant clinical improvement faster than you would see with cell-based technologies that have to grow and mature, which is basically turning the knee into a petri dish to grow cartilage. The second case is I'm sorry, I'm going to go ahead and skip past this one. So the second case that I want to cover is a 54-year-old male who's got a BMI of 28. He has pain behind the kneecap with swelling. He has crepitation here, no sensations of instability. He's fairly active, and his x-rays are really stone cold normal, so they look excellent. When we take a look at treatments for him, we started with physical therapy, injections, gel, and steroid. And then when we looked at his MRI after failing that, we saw that he had really significant isolated patellar chondral loss. Performing an arthroscopy, you can see his trochlea is really completely normal. His medial tibial femoral joints are normal. So this is a gentleman that's in his 50s with grade 4 cartilage defect on the patella. And I elected to perform, as opposed to a patellofemoral arthroplasty, a resurfacing of a half normal joint. This is what it looked like during the time of arthrotomy. I performed a lateral lengthening approach that prepared for a large plug-based osteochondral allograft and performed that with an accessory microfracture where we couldn't get the graft to match with a tibial tubercle osteotomy. Ultimately, he did very well, and you can see that you can actually get really good matching in the patella. And this shows that this one had good cartilage and subchondral bone matching in a large plug. And post-operatively, he did great. And at 9 months, he hiked the Grand Canyon rim to rim. So he was very happy, and a little bit of an atypical usage, but I think potentially appropriate. So I'll go ahead and stop there. And Matt or Eric, if you have any questions or comments, we can go through that. And I know there was some comments in the chat about the use of biologics and how you pick between BMAC and PRP and to use it for all patients. So if you want to maybe mention what you do, you guys have mentioned it somewhat, but if you have any further comments.
So I've gone back and forth. I've used PRP, I've used BMAC, I've used amniotic suspension allograft, and we're actually, part of the decision making for me is we're studying it. So I did 6-month periods of each, and then we're getting follow-up MRIs. So stay tuned.
Hey guys, can you hear me or?
Yeah, you're back.
Okay, sorry, it froze up on me.
Hey, back.
Adam, did you hear my comment about the biologics?
No, I'm sorry, it
Did.
cut out, but
All right, so basically
Yeah,
I
at
was
the end it
saying,
cut out.
all right, so
Yeah.
I've been, we're doing a study I've used in the last number of years, PRP, BMAC, and amniotic suspension allografts. And I did like kind of 6 month to 9 month enrollments, going for each for them to have comparisons with post-op MRIs. Now that my enrollment's done and we're waiting for follow-up, I'm back to using primarily PRP. I just think it's much easier to get the PRP, have it on the back table than to get BMAC. So that's what I've been doing. I'm curious to hear what you guys do.
I've generally done PRP, and of course, insurance here in the United States doesn't take kindly to it at this point yet. So we still just have a 0232T code, and they're collecting data on it, obviously. So hopefully we'll have something down the road, but we don't see anything on the horizon in the next several years in terms of a coverage statement. That being said, I generally have used it as a value add for the patients. We're going through a big case, big surgeries, osteochondral allografts. I've just generally added that in as a value add, if you will, because just believe in it. We don't have the best evidence, Eric. I think you mentioned it, that anecdotally some of the healing looks better, I think, on our post MRIs and some of the other things with allograft. And I'm just trying to maximize, everything for some of these, challenging cases. But generally, it's been PRP. Sometimes people will ask for BMAC, and they want the highest level of stem cells. In the United States, the FDA does not allow us to concentrate stem cells, unlike other areas of the world. So we're only getting a small percentage when you look at the stem cell. There's probably other components in there, obviously, that are helping us heal. But PRP has been my workhorse, just like you, Eric.
yeah, that's great. Matt, do you want to try to answer that question in the chat about resurfacing a glenohumeral joint with osteochondral allografts? I think that some of the data suggests that depends on the etiology of the arthritis to begin with. So like glenohumeral pain pumps, those patients I think just tend to do poorly no matter what you do biologically. But what are your thoughts?
Yeah, fortunately, our intra-articular pain pumps, we did a lot with that about 8, 10, 12 years ago. There were a few patients that do surface that had, long-term, they just tolerated it for a long time. But fortunately, that hopefully epidemic is over. Those are very challenging, tough patients. But, focal ones, avascular necrosis, AVN etiologies, focal humeral head, wonderful, usually these are in younger patients with a variety of other conditions, wonderful opportunity for osteochondral allograft to the humerus. And it can be challenging to get a humeral graft. So we've used Talus quite a bit and used osteochondral cylindrical plugs, or even orange slice type size plugs for the humeral lesions. When you're looking more at early degenerative changes, obviously many times in the posterior inferior quadrant of the glenoid, or in certain inferior aspects of the humerus where you start to get those most inferior spurs. I have done some resurfacings in those patients for whatever etiology. Anchor arthropathy or just post-instability arthropathy is one that we've dabbled in a little bit. I will tell you, just like everything else in the knee, the unipolar lesions are better than the bipolar. The humeral-based lesions, unipolar, are also better than the glenoid-based lesions in terms of the overall treatment. But we're talking probably less than 25 patients I've done, and most of these have been very young, under the age of 25 or 28, with no other great options. But at the end of the day, they'll need metal resurfacing and or plastic.
Hey, Adam.
They do a nice job of bridging, for sure.
Adam, your summary was great. I think for the crowd, could you go into a little more detail about your threshold, what your tolerance is for size matching? I agree with you. For smaller lesions, contralateral I've been using, but let's just go straight up to lateral. Is it 5% mismatch, 10%? Do you think one aspect's more important than the other, or are you taking all comers?
Yeah, I think that the availability for femoral condyles are good enough that I tend to not accept a condyle width that's smaller than my recipient. So I will take the same or bigger. And I don't know that I have a bigger cutoff, but they can usually, something is usually available that's within 5 millimeters. And so that's really what I would shoot for. The trochlea and the patella are a totally different animal, and I have less tolerance for differences there. And so I really try to match cartilage width and height on the patella, and then get a relatively similar dysplasia grade, which is not always possible. If it's a far lateral facet lesion, it doesn't really matter as long as the lateral facet of the donor is big enough. But if it crosses and you get somebody that has a Weiberg 3 patella and then you get a Weiberg 1, you know, it can be a little bit of an issue, especially if the trochlea is still going to be dysplastic after you put that in. So, and then maybe just on the trochlea itself, I base it on trochlear width is my primary measurement. And I almost always get mismatch on a trochlea, and I just try to get the proximal distal aspect of the deepest part of the groove, if it crosses the groove, to match, and then I will trim with a knife anything that is proud. But those are the deepest plugs I put in to try to match that surface. Does that answer your question, Eric?
Very well.
Well, that was great. You know, thank you both very much. It was educational and fun and nice to see you guys. And thanks for everybody that tuned in. It sounds like we were able to answer some questions, and hopefully the topics were useful. And I'd like to thank ICRS and JRF for putting this on and for inviting us, because we love to be involved, and it's appreciated. The next webinar is coming up on January 13th, and it has another great panel, and they're talking about the treatment of early osteoarthritis, surviving the road to hell, how to understand it, diagnose it, treat it, and potentially prevent it. Looking at biomarkers, biologic treatment, as well as different types of imaging to evaluate for its presence. So thanks for joining, and thank you, Eric and Matt, for your expertise.
Thanks, Adam. Thanks, everyone.
Good day.
Appreciate ICRS and JRF. Thank you all. Have a great day.
Bye.